So it really is an honor to be here and connect the dots of the two institutions. There's a picture of Henry Ford Hospital, 1915. The picture right next to it is they've broken ground for a new hospital. So every 109 years, it's time to do something different. So we're pretty excited about that. My conflict of interest. So we're going to talk about the past, the present, and the future as far as sleep medicine and surgery and moving forward. And, you know, this article here, once again, is from Sleep Disorders, Stanford University, as far as the surgical treatment for obstructive sleep apnea. And so this is interesting. It's like 1980, and there are going to be several articles that come out right around that time. So that was a time of great innovation in terms of, you know, can we treat sleep apnea? And this article was about sleep apnea, and at that time, once again, the only treatment surgical was tracheostomy. So, you know, it was first described in 1969, and it was for the Pickwickian syndrome. We now call that the hypoventilation, obesity hypoventilation syndrome. This was 72 trachs, 50 with follow-up. I'm always interested when I look at articles that were published in 1980 and around, you were able to describe someone as having a short, fat neck. Today, I'm sure if it was sent to any reviewer and they said short, fat neck, it would be sent back to you or just rejected. Some of the terminology is interesting. The average AHI was 65. These were the people that had such disabling hypersomnolent sleepiness that they were being kicked out of their families. They couldn't keep a job. They, you know, couldn't participate in meals. They were just the ones that nobody could find anything to do with. And it was being attributed to their lack of involvement. It was more of a personal trait rather than it was a medical condition that caused these people to be in that situation. Cardiac arrhythmias, you know, during the sleep study, asystoles were seen in 15 patients during their sleep study. So you can only imagine that. And I'm sure somewhere on paper in this institution are those sleep studies that you will find a room with them in that. You know, oxygen desaturation below 40%. So these aren't the ones, the mild sleep apnea. These were the worst of the worst of the worst kind of thing. So along came Shiro Fujita, and this is from Henry Ford Hospital, and this was published in 1981. So right around that time, there was this burst of energy around sleep medicine. Believe it or not, there's two Shiro Fujitas. There was the one that was in Detroit, and there happened to be one back in Japan. And he wrote an article, and it was a letter to the editor in a Japanese ENT journal, and it talked about uvulopalatal for snoring. And since we happen to have a Japanese ENT who happened to get the journal and thought about snoring, he said, well, maybe we can do this for our sleep apnea patients. So once again, first series, 12 patients, 11 men, 10 were obese with short and thick necks, kind of thing. Excessive daytime sleepiness. Some patients reported nasal obstruction. So of this series of 12 patients, and it's interesting if you look at the authors, one was an ENT, one was a pulmonologist, one was a PhD, Tom Roth, who did amazing research, and one was a psychiatrist. And so those were the four people that were involved in publishing this. And so what it showed was 2/3 of the patients did really well, no further treatment. 2 patients showed a mild decrease, but I'm going to say status quo, didn't get better, didn't get worse. And then 2 actually did get worse. So 2/3 success rate. And so his response in the paper was, since there is a variable response to UPPP, it's important to determine what subgroup of the sleep apnea patients would benefit from this procedure, or whether another factor might influence the surgical results. And I'm going to say this is probably what we fought up until this day, is like, what's the right procedure for a patient that has sleep apnea? What's right and what's wrong? But that subgroup is so important to us, and that's what we continue to struggle with. So I always thought that CPAP was invented in Australia by Colin Sullivan. But in fact, Elliot Phillipson devised the first incarnation of what CPAP is, and it was a reverse paint concentrator. I don't even know what that is, but that's what it was. And he actually used it on his dog because his dog had sleep apnea. So at your next cocktail party, when you run into someone that happens to have CPAP, you can tell them the first one was on a dog. So Colin Sullivan heard about this. He came over to Toronto, just down the road from Detroit, and said, you know, we might be able to use this on patients. And so they started innovating, practicing, whatever. 1981, once again, important year, he received a patent for use on humans to be able to use that. And then Baxter International, then ResMed in 1991. I don't know, anybody in the room use CPAP? I looked it up recently. The machine now weighs 5 pounds. Back there, it was 14. And oftentimes patients will complain, I have to lug this around. It's heavy, it's, you know, whatever. And I always look at TSA because there's so many of them that are going through the belt, you know, because patients don't want to put it in their suitcase. They don't want to be left without it. But it's obviously gotten much better than it was before. So, you know, if you have a hammer, everything looks like a nail. So everyone started using UPPP for every patient that had sleep apnea. And maybe the results were 66%. Maybe they weren't quite that good. But there was an article that came out, and this is, I'm going to be saying it's still quoted to this day. And it was in Sleep about the efficacy of surgical modifications of the upper airway. And so looked at all these articles, any case series that had more than 10 patients in it. So they looked at any nasal surgery, UPPP, maxillary mandibular advancements, all those kind of things. And what they said was that you had a 50% chance of success if you do surgical treatment on a patient with sleep apnea. And so there was there are some things that just stick, and it's really hard to undo it. So everyone told their patients, you got a 50-50 chance of it working. And I'm going to say, if I say individuals, the sleep community, whether it was pulmonologists, whether it was your neurologist, anybody involved. And so they would tell their patients, don't go see a surgeon. You got a 50-50 chance of it working. It's not worth it. The other thing that was in it was that it's more likely if you have mild sleep apnea to have surgery that it would be successful. And that's another thing that it's really hard to undo when something like that happens. So, and the other thing that was said, you know, these are small cohorts of patients, small sample size, limited follow-up, and patient selection was not clear as to why a certain procedure was chosen. So the part about the mild sleep apnea, follow-up study, and this was done at Henry Ford, Brent Sr., and he looked at patients that had mild sleep apnea. He got the pre and the post-sleep study, and it showed that 40% had a decrease in RDI, 60% had an increase. So once again, and this is still being quoted, if you have mild sleep apnea, surgical treatment is not more likely to help. So I think the important takeaway of that is that the severity of obstructive sleep apnea is independent of the likelihood of success with surgery. So that's not what's going to make a difference in whether you do well or not. So if you want to talk a battleground at this time, it was a battleground between surgery and no surgery. So the Journal of Clinical Sleep Medicine, 2005, had opposing editorials. And Barbara Phillips wrote this, and she was at University of Kentucky. She was president of the American Academy of Sleep Medicine at the time. And, you know, she called us out. Otolaryngologists have failed to demonstrate clear-cut benefits for sleep apnea. Outcome variables in surgical trials are subjective and trivial. And what she was referring to was what we would call PROMs, patient-reported outcomes. Patients felt better. They weren't sleepy anymore. They did well. They were brought back into the fold of their families. And so that was trivial and not important. And then they said, if you did a sleep study, it wasn't well interpreted. I have to be honest, all the sleep studies were done by sleep medicine at that time. Surgical success. So you might have an AHI of 20, and that was considered deadly. And so that was part of it. Only UPPP, it's 50-50. Long-term follow-up is incomplete. By and large, patients felt better, so they didn't come back once a year to get checked. They didn't come back for supplies because they didn't need supplies. And so that was it. And if CPAP doesn't work or isn't tolerated, other treatments are at least as good as upper airway surgery. All right, so this is where Stanford comes in. So the con was brought in by Dr. Powell, who said surgeon's role in sleep apnea is a major one. It's time for surgeon to bring a breath of fresh air to our patients that's not from a CPAP device. Medicine's lack of recognition isn't justified. We just have to recognize that patients aren't tolerant of CPAP. 1 year, 2 years, 3 years, 4 years, 40%. In urban settings, there's 40% adherence. And we've all seen patients that love CPAP. They use it every day. It's the best thing ever. That's not the majority of patients. And so he said, we are tired of the tail end of the dog as patients in sleep medicine would benefit by our skills. So basically saying we need to be collaborative, we need to be collegial. The one thing is I didn't know what tail end of the dog meant. And it means a smaller or unimportant part of something. So 2005, 2006, it's really a very sad time for ENT and sleep apnea. 2008 was the first time that sleep medicine became an American Board of Medical Specialties board certification. And so 2008, for some of us in the room, we took that test for the first time. You went to a review class ahead of time. And if they mentioned surgery, all they said was, no, bad. There was never going to be a question on the test that said, oh, sleep apnea in this patient with 4+ tonsils or something like that. So this is, I think, some really interesting articles. This was written by Michael Friedman, Chicago, and it was a retrospective study. And he basically looked back at 134 patients. And what he looked at was palate position and tonsils, also BMI. And the success, this is from that Shear article, 50% decrease in AHI and AHI less than 20. And he came up with a staging system. And basically a staging system, we use it for cancer. We use it for many things, right? How bad it is, this, that, and the other thing. And he basically said, if you have a favorable palate position and large tonsils, and the BMI is less than 40, stage 1, 2, 3, 4. He believed if a BMI was greater than 40, you shouldn't operate on them. They should have bariatric surgery at the time. That would improve their sleep apnea, but surgery wouldn't be helpful. And what he showed was that if you have a favorable palate position and large tonsils, you have an 80% success rate. If you are a Malampati 4, the high riding tongue and no tonsils, you're down to an 8% success rate. So to me, that's really very helpful. I was able to look at patients and say, I think I can do you some good versus, this isn't going to work well for you. I would always say, you don't want to have a procedure that isn't helpful, and I don't want to do a procedure that isn't helpful for you. So that Malampati 4, the high riding tongue part of it, became very important. And so the idea was, okay, if we take care of the palate and we take care of the tonsils and treat the nose in addition to it, and we reduce the size of the base of the tongue, are we going to get to where we need to go? And so this is from Dr. Chabot, this is from France, and he did an external approach. He had 10 males where he did hyoepiglottoplasty, and you could see UPPP, septoplasty, turbinate, all this kind of stuff. He did an external excision to get to all of this, and he had an 80% success rate. And I'm going to, every time we talk about success rate, it's going to be, okay, what's the success rate? 80%, keep track, do all that kind of thing. What's interesting, I'm going to say about this, is that, the procedure, external, separating, getting to the base of the tongue, but the results, they were in the ICU overnight, NG feeding for 8 days, 5 cases of submental abscesses. I think your NSQIP data would really go south if you had 50% of your patients ending up with abscesses, in the postoperative period. Once again, 80% success. And so then here we came to TORS. Now, TORS, you could do it, through the oral cavity. You didn't make an external incision, minimally invasive. The thing that's interesting about it is that TORS was not approved for benign tumors. It was only approved for malignant tumors. So it was an off-label use. Da Vinci never supported the articles that were written for sleep apnea because it wasn't an indication. And so everybody went out. We talked about the Academy meeting. If you went to the meetings in 2017, everything was talked about was TORS. That's all that people talked about. And so meta-analysis about it, looking at it, they had this done. They would often have UPPP either before or after, but when they got it together, you had 75% success rate. And then came upper airway stimulation. And this is 2014. This was published. 126 participants, moderate to severe sleep apnea, majority male. The BMI was 28. So 28, 30 is what we call obesity. They show AHI decrease, oxygen desaturation index decrease. And it's an uncontrolled cohort study. And it showed upper airway stimulator improvements in objective and subjective measures. And, we often call primary endpoints and secondary endpoints. Primary being, it's usually always an AHI, secondary being, quality of life, Epworth Sleepiness Scale, hypersomnolence, something like that. This one, the original article, there was a sensing lead. It was 3 incisions. Okay, so they followed it up, 1 year, 2 year, 3 years. And the limitations of the study, and I think everybody has to be aware of this, is that there's some selection bias of only including responders to upper airway stimulation. So 126 received the implant. And then it came down to 48. So they would test them with a sleep study after the implant. Those that responded then went into, you had activation of it, you didn't, so kind of a crossover, and see how you did. So if you look at this, the full picture of it, and this is in the original article, 929 patients were enrolled. So from that 929, they were excluded for different reasons. And it got down to that 46. So huge cohort starting, right? Went down to 46. And then really 23, they got tested after that. Exclusion criteria, neuromuscular diseases, any palsy, COPD, heart failure, uncontrolled hypertension, all this kind of stuff. So they had the best of the best of the best in terms of those that got the procedure and then were tested afterward. So to be that. Now, if you were to look at 46 out of the 929, it was a 4.9% success. But if you looked at those 46, it was much different. So I'm sure you're seeing all the advertisements on TV here, the direct-to-consumer advertisements, I would assume, on TV for Inspire and on the radio and all that. And I can guarantee you that the exclusion criteria that were here are no longer being used for that population. So success rate, once again, 80% in terms of looking at it for UPPP. Tonsillectomy, interesting enough, when you look at many of the articles, if someone has large tonsils and if you don't touch the palate, you just do the tonsils, you have almost the exact same success rate, which begs the question, when we do a UPPP on somebody that has big tonsils, does the UPPP add anything, or is it just the tonsils alone that makes the difference? So remember, tonsillectomy itself is fine. We talked about TORS, base of tongue, and hypoglossal nerve stimulator. These were the number of publications that came out for these procedures. So, around 2014, 15, it was a dead heat between TORS and hypoglossal nerve stimulators. And now you can see there are very few articles being written about TORS anymore. I mean, and there probably are some patients with lingual tonsil hypertrophy that would be aided by this, but by and large, it's just not where it's at. And then, of course, the hypoglossal nerve stimulator has kind of gone on through the roof. 80% success. We have not gotten to 100%. We just haven't. And so the question is, why is that? So this is one of my favorite articles. And I would certainly suggest people to get it, to look at it, and keep it in your mind when you think about that. Because this talks about anatomic and non-anatomic considerations. And as surgeons, we always think about anatomic. If we take out more, if we open it up more, it's going to get better. This looks at these patients, and it turns out there are non-anatomic causes that are really significant. And one of them is genioglossus muscle responsiveness. And I used to call it a stupid upper airway, but that's not very politically correct. So I'm calling it an incompetent upper airway, much like an incompetent larynx, right? We're familiar with that. It may be insensate, it doesn't close, patients aspirate. And so there are patients that have an incompetent upper airway. There's something called arousal threshold. Before patients even have an apnea, they wake themselves up. And if you're falling asleep in this room, you know how you jerk yourself awake? That kind of thing. So even before you have an apnea, you have an arousal. And those may be the patients that are hypersomnolent, because even though they're not obstructed, they are the ones that keep waking themselves up at night. A respiratory control instability. They hyperventilate, they pause for a second, they hyperventilate, and so they have problems with respiratory control. So they looked at this group of patients, 75 men and women, with and without sleep apnea, 20 to 65, 3 different nights. They put pressure sensor needles in the base of tongue. How they got them to do it on 3 separate nights, I don't know, but they did. 36% patients had problems with genioglossal muscle responsiveness, which basically means no matter how wide you open that airway, it's not going to work. It's not going to open up with negative pressure. Low arousal threshold, high loop gain, and some had more than one thing going on. So that certainly helps us understand why we're not going to get to that 100% with a surgical procedure unless we're able to identify these patients ahead of time. So this is an example of the collapsibility of the upper airway. So you see the P crit, and the P crit is the pressure at which the airway closes, and AHI is the number of vents they have. And so you can kind of see on this that there are patients, and I'm going to say the open colored circles are those patients that have sleep apnea. So you have a patient who has an AHI of 120, and it's at positive 5 centimeters of pressure. So you can't get better. I mean, that would be a CPAP of 5, and they still have sleep apnea at 120. So that's what I would call an incompetent upper airway. Sleep apnea patients, this group, are the ones that are trouble. Now you have on the left side, you can go to negative 15, and those patients don't have sleep apnea. They're the normal patients. So they're walking around amongst us, and when they go to sleep, they have an incompetent upper airway. So the control median AHI of 2, here are the ones, they can go to positive pressure, and they have this huge. This is interesting because basically when you do different interventions, you can change that P crit. You can impact whether the airway stays open or whether they're going to have apnea. So mandibular, and so this PALM 2A, moderately collapsible upper airway, absence of non-anatomic traits. And so they have an absence of non-anatomic traits. These are the things that you can make a difference in. Mandibular advancement, 2.3 centimeters P crit. UPPP, 3.3. And positional, I'm going to say almost never do we advise patients to sleep on their side instead of their back, but in fact, that may be enough to obliterate, some of the sleep apnea. And then weight loss is just so significant. You decrease it by 17%, 7 centimeters of water, if you think of it in terms of CPAP. So interesting. And then there are some patients that are just poor muscle responsiveness, everything else. And you really should think of non-anatomic interventions to see how they do. The last couple years, pharmaceutical management of sleep apnea, OSA, and in a couple different ways. One is to improve the muscle responsiveness of the upper airway. So think about a medication that takes that from an incompetent upper airway to a competent upper airway, one that responds with negative pressure to open up the airway. Calcium channel blockers, hypnotics, and hypnotics have something to do with that low arousal threshold, as well as the patients that have the loop gain. And then the GLP-1 agonists. So, for years, ENTs were told, use CPAP, surgery doesn't work. And then a pill comes out, and every patient at Henry Ford that was on CPAP got a letter or a phone call that said, hey, how would you like to be on this study? And it's Mariposa. And they were looking for patients that were using CPAP, whether successfully, whether not, and say, hey, how would you like to take a pill instead of putting a mask on your face every night? They got a fair amount of response to that. And so it was a randomized, double-blind, placebo-controlled, parallel-arm, dose-finding 1-month study for AHI, hypoxic burden, symptom response versus placebo. So atomoxetine and an anti-muscarinic. And the atomoxetine is sometimes used with ADHD. It's non-habit forming, non-addictive medication. And then the oxybutylene helps with sleep consolidation so that the noradrenergic doesn't make you wake up more frequently than you should. So they went ahead, several studies with this, that looking at it, they found that it does decrease the AHI, oxygen desaturation index improves as well, and the respiratory arousal threshold was improved. And that's that part that we think has something to do with hypersomnolence the next day. The most common adverse event was the insomnia, which I'm going to say probably isn't surprising because anything that I'm going to say is alerting, increases muscle tone, the noradrenergics, that would probably be part of the issue. So this is another study where they looked at another agent, once again, looking at, will this help? So exciting times. A medication, a pill you take once a day, doesn't mean surgery, doesn't mean implant, doesn't mean wearing CPAP every night. So it has finished its clinical trial, probably will be coming out soon through the FDA, be approved for it. So colleagues in Australia are working on a calcium channel blocker to increase the upper airway dilator muscle activity, reduces pharyngeal collapsibility. And this is a nasal spray. So once again, we are looking at different mechanisms to target those individuals that the upper airway musculature is not responsive in a way we would expect it to be. So of course, with the medications for weight loss that have come out, the original first medicine for the GLP-1 agonist, it was for diabetes and then hypertension, but it did not have an indication for sleep apnea. And so once again, it would be an off-label use if you were to use it that way. And so tirzepatide, had a study, SURMOUNT, OSA, phase 3, and it was for patients with sleep apnea. BMI greater than 30, obstructive sleep apnea, AHI greater than 15. Primary endpoint, AHI, secondary, hypoxic burden, functional outcomes, cardiometabolic markers. So April 17th of this year, the first arm were for those patients that had sleep apnea, didn't use CPAP. Second arm was those patients that had sleep apnea and used CPAP. And it showed change in AHI and change in body weight. And we already know that if you change it 20%, it's going to have a marked impact on your sleep apnea. So this article just came out July 1st. Once again, this is an exciting time. There was like 1981, and now, right now, is the time where all these things are coming out and just lots of changes. So they looked at this. They looked at C-reactive protein because, the question is there an inflammatory marker that goes along with AHI or with sleep apnea that we just haven't paid attention to. Sleep reported outcome and systolic blood pressure. So, here it is, the top left, change in apnea hypopnea index, this tirzepatide, you could see the change versus the placebo. To the right, it was in trial 2. Those were the patients that were already on CPAP. So it didn't make a difference whether you used CPAP before you used it or you didn't. And then the body weight for the trial 1 is on the left, lower left, and on the lower right. So significant change in weight loss, 20%, that impacts it. So, the battle between surgery and CPAP, we started that with Barbara Phillips and Dr. Powell. And the question is really efficacy. So if you're in a lab and somebody puts a mask on you and they say, lay on your back, lay on your back, lay on your back, it's 100% effective. And then you get the device and you go home and you don't know how to hook it up and you don't want to travel with it and your spouse doesn't like it making noise. And I know they're much quieter than they used to be. And I have, families or couples that they're both on CPAP and it works great and all that kind of stuff. But effectiveness is, okay, what's it like when you use it every day? So this is another one of my favorite studies, and this is from 2004. This looked at veterans with sleep apnea. So this was Ed Weaver, Bevan Yu, and they looked in the veterans data bank, 1997, 2001. They looked at treatment groups. They were compared for age, gender, race, year treatment was initiated, and comorbidities. They did not have the severity of the sleep apnea. They did not have whether or not CPAP was being used or not. And if you want to accept that UPPP is successful 50% of the time, and maybe 50% of the time people use CPAP, we're going to say, okay, it's about the same. But what they found, and this was a fairly large number of patients, that at any 1 year increment, the UPPP patients were 30% more likely to be alive than the CPAP patients were. So if we have 2 modalities, and I'm going to say they're fairly simple and effectiveness kind of thing, it's just interesting that the UPPP patients were more likely to survive than the CPAP patients. This is a great article. And so different countries treat sleep apnea differently. In Brazil, nobody has CPAP. It's just not available. In South Korea, if you have sleep apnea, you're going to have surgery. I'm going to say if you're in Netherlands, you're going to have positional therapy. It's very different. In Canada, there are no hypoglossal nerve stimulators. They cannot import them. They're not legal to be implanted, even if you wanted to pay cash. It's not that it's not a benefit. You can't use it. It's just not approved. So when we talk about this in treatments, it does vary by country to country. Okay, so South Korea has a medical record, an electronic medical record. They have national health insurance, so they know everything that happens for everybody everywhere, what goes on. And so they looked at data, and they looked at patients that had a diagnosis of sleep apnea and had surgery as opposed to those that just had usual treatment, which was, take care of yourself, get enough sleep, do all that kind of thing. The primary endpoints were newly diagnosed myocardial infarction, congestive heart failure, atrial fibrillation. And once again, this went for about 7 years in terms of how long they studied these patients. And if you look at, short, small cohort, short follow-up, all that kind of stuff, this really looks at a lot of things. So they looked at this, and what they looked at, and once again, across the top is congestive heart failure, atrial fibrillation, the control, and myocardial infarction on the left. So the control is the first line, and obstructive sleep apnea, and survival probability. So a diagnosis of obstructive sleep apnea for newly diagnosed these conditions, you could see that the obstructive sleep apnea patients fared worse. The bottom one was those patients that had UPPP. And, once again, this is a fairly long follow-up. So myocardial infarction, if you had a UPPP, how this is possible, I don't know. It's better than the control group. It's better than the congestive heart failure. And the atrial fibrillation, it's exactly the same. So many patients will get referred to sleep medicine because they say, I've got atrial fibrillation. The doctor says that if I get my sleep apnea controlled, then I'll do better. Unclear if that's the case. So 2016, there was a study, and it's interesting because 2018 was when we had to take the board exam again for sleep medicine. It was every 10 years. This came out 2 years ahead of time. And so it was patients, they had about 3,000 adults that had moderate to severe obstructive sleep apnea and cardiovascular disease. And we've all been told that if you have sleep apnea and if you take and you use it, your cardiovascular disease, it'll stabilize it. It won't get worse. You won't have more problems. It'll be helpful, right? I mean, that's the indication to use it. So they were randomized to usual care, receiving CPAP. Primary was death, cardiovascular disease, that kind of thing. Secondary endpoints, cardiovascular outcomes, but quality of life, snoring, daytime sleepiness, and mood. New England Journal of Medicine, 2016, it came out. And basically what it showed was that CPAP didn't make you live longer. You didn't do any better. And why are we doing this? It was the same as usual care. And usual care was, exercise, eat right, get enough sleep, take care of yourself kind of stuff. So no difference in outcomes for that. So once again, we all go to Chicago, we're studying for our exam again. And all of a sudden, the mood in the room has changed because pulmonologists could no longer say, we have the golden answer to sleep apnea, use CPAP. Well, what they did find was that the average individual that was on the CPAP arm used it 3.3 hours a night. So clearly, if they had sleep apnea, using it 3 hours a night, it's not all night, every night. No difference in primary outcomes. It did reduce snoring, daytime sleepiness, improved health-related quality of life, and mood. So, small sample size. I go back to the sheer thing. So, the Journal of Clinical Sleep Medicine comes out after all of these things, and they said, okay, we did a systematic review of long-term health outcomes of CPAP. This came out June of this year. Does CPAP help patients with obstructive sleep apnea? Unanswered, unclear. For primary outcomes, we agree for those patients, it may make them feel better, they may be less sleepy, but guess what? You need randomized controlled trials, comparative studies. It just doesn't show that CPAP, for those patients that don't have problems with hypersomnolence. This comes out, and this was 2020, but pretty much the same thing. Indications for CPAP or treatment are basically patients that are sleepy, excessive daytime sleepiness, or resistant hypertension. So the two indications. Resistant hypertension is 3 medications and still not controlled. Those are the indications. Managing asymptomatic sleep apnea to reduce cardiovascular, cerebrovascular events is not currently supported by high quality evidence. And the other thing is, do we recommend patients to do weight loss and exercise? And there are studies that show exercise by itself will increase the muscle tone. So even if you don't change BMI, it will improve the muscle tone of the upper airway and do better. So are we treating the wrong thing? Are we treating AHI for diagnosis and treatment of sleep apnea? And we're treating that, but it's not really what indicates the disease process. And I'm going to say, some of us in the room, when we went to medical school, it was fasting blood glucose for diabetes. I'm going to say today it's glycosylated hemoglobin. So we haven't yet found the metric, I'm going to say, for obstructive sleep apnea. And that's why it's so exciting, and all the residents here and everybody should get excited about doing a fellowship and going into sleep medicine, because we are at that point where we need to start talking about those things. And it's not just ENT talking about this, okay? So this is the Journal of Clinical Sleep Medicine, trying to distill obstructive sleep apnea into mild, moderate, severe. It doesn't talk about event duration, hypoxemia, heart rate, sleep stage, body dependence. And it's like, that may be why all of our negative results. you know, in all these studies. It's not showing we're doing anything. Another one, AHI, not all it's cracked up to be. At this point, we need to consider that either treating obstructive sleep apnea is inconsequential. We're not doing anything with all those CPAP machines, our surgeries, et cetera, or we are not accurately capturing at-risk individuals. So this again came out this summer. You know, should we be looking at ventilatory burden? So instead of AHI, you may hear about VB, Verno classification, and it's basically based on your symptomatology. It's not based on what the sleep shows. And so, once again, we're getting to that point where we need to talk about it. Hypoxic burden, what's the time spent under that curve of normal oxygenation during sleep? And then, you know, the point of research is to find out. And I get excited with the idea of, we talk about artificial intelligence, we talk about big data. You know, the sleep studies are all now computerized. And if you want to go back to look to the original sleep studies where they were on paper and, you know, they were a mile long and 30-second epochs, if we can capture all that and then put it with survival, put it with those outcomes, that's where we need to go. So exciting time. And of course, I have to give, you know, a shout out for the sleep medicine fellowships. You know, there's 80 programs. There are actually 7 different specialties that can sit for sleep medicine. And most people think, oh, it's, you know, got to be pulmonary, it's got to be this. Pediatrics, neurology, family medicine, internal medicine, anesthesia, otolaryngology can all get sleep medicine sub-certification through the American Board of Otolaryngology, but it rolls up to ABIM that administers the test and does all that kind of thing. There was a period of time where you could get grandfathered. So I was grandfathered in. I did have to take the exam ×2 kind of thing. Now they have longitudinal LKA, longitudinal knowledge assessments. Every 3 months, I get 30 questions to answer. And hopefully I won't have to take this test again where I go to the testing center and do it. And so it's also, I'm going to say, the easiest fellowship you'll ever do. You will maybe get called in the middle of the night that someone's just dying, but there's a protocol and they just add oxygen. So, and you will be the most wanted provider because everybody, it's just such an exciting time for sleep medicine that, yeah, you'd be very popular. So I wanted to leave some time for questions. And so thank you.
Fantastic lecture. What's the role of MMA in all of this?
Well, that's it. I mean, that is it. So, you know, MMA, I think there are some people who have, and you know this, I mean, and it's probably, I'm looking at their side profile, I'm looking at all kinds of stuff. And so absolutely, I'm sure for some people, it's going to be, you know, an MMA is appropriate. At the same time, if they have this incompetent upper airway, you know, so to make sure that when you start it, and maybe that's not even bad. I mean, yes, so you do that and they'll also look better. And then at the same time, we're now going to have a pill, so you may be able to use 2 things. So we always like one and done, you know, one and done. But in the world, we know that oftentimes one antihypertensive isn't going to do it. One diabetic medicine isn't going to do it. So I think this ability to be able to titrate the treatment is going to be what's going to make it even more exciting. I don't know if that answers it. Okay.
Kathy, so a couple of questions. We know I am one of those as well, that we surgeons specifically, we suffer with AHI for too long. Let's put it this way. And then again, there's significant variability, night to night, interrators, all that kind of stuff. And there's that paper by Heinzer saying that, hey, listen, 80% of males end up having a positive sleep test anyway, 60% of females end up having a positive sleep test anyway. When is it that you feel comfortable saying, you know what, this positive sleep test is not a problem, you don't need to do anything about it?
You know, it's really interesting. So I have some patients, and you know, they're not sleepy, they're not hypertensive, they're on no meds, and they have an AHI, I'm going to say of 80. I say it's okay. The only time I'm going to say it becomes more significant is if they have a commercial driver's license, because once they're identified, then they come to you and they say this. But honestly, if so, I am okay. You are not hypersomnolent. You're not, you don't have high blood pressure. I mean, as I said, I have, and a little old lady that's 85, you know, and it, you know, for these outcomes, it's like 10 years kind of thing. Like there's no difference. It's like, and often patients, they may have that low arousal threshold that when CPAP wakes them up, they're actually sleeping worse. They feel worse. So I think taking into consideration the PROMs, the patient-reported outcomes, are so important, just so important. And initially, that's what they said, inconsequential, unimportant. What we're learning is that's the important. That's where the risk comes in. They're going to be the train conductor that goes off the tracks and kills people, you know, the truck driver that falls asleep and crashes into somebody. So that hypersomnolence is very important, as well as the quality of life. You know, they're not there. The presenteeism at their job and their family, important. And resistant. And once again, this isn't an ENT. These are the medical people that are saying those are the ones that need to get treated and are important.
Yeah, because I feel that sometimes the sleep medicine community has such a hard time not telling patients, hey, listen, you don't need to do anything.
And I share some of these articles, and some of them are not very difficult.
I can see
that one JAMA article I showed you. It's very, you know, exercise, you know, some weight loss, diet. I mean, they're very easy to understand. I'm going, you know, this is your decision. And I understand if you go on the internet, you'll see all kinds of craziness, you know, kind of stuff. But we just don't have the evidence after this amount of time to say, this is going to save your life. Now, if you snore, that may be another thing because your bed partner may take you out. But outside of that, it's like, okay, no, you'll be okay.
I did actually, on the subject of snoring, you had mentioned earlier about that article when they were comparing head to head with Dr. Powell, like the surgeons don't have a role in this. And if you just not talk about sleep apnea for a second, but you just talk about the impact of snoring on people's lives and the role that maybe otolaryngologists have on that, has that been quantified? I mean, you know, when people come to you,
I think it's a really rich area. So I had done one study, and what we looked at was patients that had sleep apnea and snored, and patients that just snored. So we went to the sleep center, found all those, you know, sleep studies, and then we did ultrasound vascular studies, and there was more endothelial disruption in the carotids of those patients that snored and had, and in both. Even if they didn't have sleep apnea, they just snored. So it's possible. And then there was an article in Nature that talked about endothelial disruption because they did it in animals in terms of vibration and all that kind of stuff. It may also be the reason why some upper airways are incompetent. It could be much like a repetitive stress injury. Snoring has desensitized it and caused a neuropathy. So snoring could well be very important. There was also a study done at Mayo Clinic that talked about the bed partner of a snorer. One night they did CPAP and one night snoring, and the bed partner loses an hour of sleep a night. Hour of sleep. And so in a whole week, that's a whole night's sleep, right? So they're crabby, they're miserable, there's your, you know, social dysfunction and all that kind of stuff. So I do think, and insurance considers snoring cosmetic, so it doesn't want to treat it. Now, for those patients that may have mild sleep apnea that we say, oh, we don't want to do anything, maybe treating that snoring would be helpful. And there's so many apps now, you know, there's Snore Lab, people can document how bad their snoring is. You know, the Apple Watch has now been approved for use for sleep apnea. So it's this next jump in terms of diagnosis, but it's really, who do you want to treat and why do you want to treat them? Are you treating a number? Are you treating the patient? Are you making them feel better, do better? And, you know, the resistant hypertension. Other questions, ideas, thoughts? As I said, I think it's a incredibly exciting time for research, for ideas, for thoughts, and that kind of thing. And so getting involved in it is.
And I keep repeating this to the residents. I think this the why we treat sleep apnea. A lot of the times, again, that question comes back for the surgeon to define, because many of our sleep medicine physicians or colleagues, they may just have CPAP. as an offer, and then patients can use CPAP. They send to us then this distillation of like why do we need to treat and how far we go, and is this how far should we go to treat this, ends up in the hands of surgeons most of the time. So the question I have sometimes is, how do you make the sleep medicine physician have more skin in the game and recommend surgery? That is something that we are doing. For example, and especially some of those, we start incorporating PPE. We have a psychologist who knows sleep. And you know what? You tell me that this patient actually will benefit from an Inspire. Yeah. Help me here. Because we have all those 80-year-olds now who want Inspire. I know. So that is another thing that we are incorporating.
I appreciate that. We had a psychologist involved in that. We have a collaborative. We have one sleep lab, and we have ENT, and we've got neurology, and we've got pulmonary, and the fellows, that all work together. So there's a recognition. It's almost like a tumor board. Okay, failed this. Let's do this. How about this? Let's do this. Does this patient need anything? What's the point? Give it back. It's not working, and all that. So I think all of that, comes into play with recognition. And, the American Academy of Sleep Medicine, much like American Academy of Otolaryngology has their clinical practice guidelines and that, and they're still saying treat. Although you see right here in the literature right now, they're saying we got nothing. We need to do better. But the other thing is, if in medicine, and this is kind of sad, it takes 14 years from the time something comes out until it's adopted. Notwithstanding the internet, notwithstanding everything else that we know that you can find out instantaneously, change is difficult, and if you've spent your entire life treating this AHI, it's hard to change it.
Yes.
It's hard to change it. So recognizing that there is a shift, a sea change in what we know, and how we're going to be able to treat it is just really important, and recognizing it. And it's easy to get discouraged because, as you say, how come they're not getting it? How come we're still putting CPAP on 85-year-old ladies? Because, kind of thing.
Yep. I do have a question here for our PEDS team, Mikey. She's asking, I know the answer, but what are your thoughts on myofunctional therapy and tongue therapy exercises for sleep apnea?
Yeah, and so I was at a session and I think it was Eric Kazarian said, no, stupid, don't. And I just think it's one of those things. I'm really hesitant to say that. So I had a patient, the whole didgeridoo. There was an article in the British Medical Journal that didgeridoo was suggested for sleep apnea, and it's basically muscle. Now, if we say exercise without a change in BMI increases or it helps with sleep apnea, decreases once again the AHI, but makes you feel better, fill in the blank, then myofunctional therapy shouldn't be that much different. It's a type of exercise, it's muscle therapy, and we also know in a subset of patients, and that's the thing, treating that subset of patients. Who are those patients with the incompetent upper airway? And maybe exercise will help them. Maybe it's an insensate, dysfunctional, muscle fibers just don't contract. Those may also be the ones that are the non-responders to Inspire. And so it's really hard. You're not going to get every patient to go to the sleep lab, put in these needles to see what the peak crit is. But I'm wondering if AutoPAP would be a surrogate for that. So if someone's on 18, and you've probably seen some patients, they're on 18, 19, 20, and they're still not controlled, and they're thin as a rail, you're like, what is this? So that may be those patients. And so I think, large data is getting several centers together that are doing Inspire, the non-responders, and looking to see what their AutoPAP pressures were before. And is there that kind of cut at a certain point? They're not going to respond. They just don't have the muscles tone, the innervation to be able to make a difference.
Kathy, thank you. This was a treat. Thank you so much for that.